Welcome back to Clot Conversations, the podcast where we cover some of the latest work in the world of thrombosis. I'm David Airdrie, Executive Director of Thrombosis Canada, and I'm thrilled to be joined once again by our co-hosts, Dr. Jamil Abdurrahman from Toronto General Hospital and Dr. Maha Othman from Queen's University in Kingston. Get ready for another insightful discussion, and thank you for being a listener.
In this episode, we will be discussing a publication covering recent research from the Journal of Thrombosis and Haemostasis entitled Performance of Clinical Decision Rules in Patients Presenting with Suspected Recurrent Venous Thromboembolism, a multicenter prospective cohort study. And we are very pleased to have two of the authors join us today, Dr. Vicky Mai and Dr. Grégoire Le Gal.
Dr. Vicky Mai is a clinician at the University Institute of Cardiology and Pneumonology of Quebec, Laval University, Faculty of Medicine. Dr. Mai's research focuses on pulmonary vascular disease, with a particular interest in venous thromboembolic disease. Her work focuses on the diagnosis and treatment of venous thromboembolic disease in various populations, including obese patients, patients with neoplasia, patients with chronic obstructive pulmonary disease, and patients with a history of venous thromboembolic disease. And Dr. Grégoire Le Gal, a professor in the Department of Medicine at the University of Ottawa, the lead in the thrombosis program, Division of Hematology at Ottawa Hospital, and a senior scientist, director of the Inflammation and Chronic Diseases program at the Ottawa Hospital Research Institute. He was born and trained in France. His primary research interest is diagnosis and management of venous thromboembolism. He was the recipient of the 2024 Chrétien Research of the Year Award. He has over 500 peer-reviewed publications in general internal medicine and specialized journals, and he is the co-director of CanVector, the Canadian Venous Thromboembolism Research Network. It's great to have you both here today. Thank you for participating in our podcast, and we'll get started with some questions.
Well, we're very excited to have you both with us today, and I'm going to go ahead with the first question. And we're curious to maybe help us understand, why is diagnosing recurrent VTE in patients with a previous VTE is a challenge?
Yeah, it is a challenging situation. First, from a patient perspective, right? When you've had a clot, you obviously worry always that you might get another one. And for clinicians, maybe sometimes you're like, oh, it's again the same symptoms. Maybe they are overthinking it, and we know that residual symptoms or symptoms of the post-thrombotic syndrome or the post-PE syndrome actually do mimic the symptoms of acute clots. So, and we know that the PTS comes by flares, right? So it's very easy for patients to have these thoughts. And so that's really one of the challenge number one, I think. But contrary, and we'll see later with the results, but actually they're right to be worried. And more often than not, we do confirm that they do have recurrent clots. So that's a message, a super important message from the study. The other challenge is that our main tools to diagnose recurrent clots are the pre-test probability, the D-dimer, and then the imaging test. And in the pre-test probability scores that we use, having had a previous clot usually gives you points. So you're much more likely to be classified as being high pre-test probability than not when you had a previous VTE. And that classification is the one that helps triaging who is eligible to get a D-dimer test, non-invasive test, versus the ones who should go straight to imaging. So more patients have to go straight to imaging. Even if they don't have to, if they are eligible for D-dimer, we know from previous studies that when you have had a blood clot before, your D-dimer tends to be higher than other patients. So again, here, more people will be directed to imaging. And then when you arrive at the imaging step, the challenge is that many patients with previous blood clots do have residual thrombosis or PEs, and sometimes it's hard to know whether these are scars from the previous episode versus a new recurrent event. So all that in a nutshell to say that it's a common situation. People often come back with suspected recurrent event. The symptoms are tricky to distinguish acute clot from sequels or consequences from the previous one. And the diagnosis strategy is a bit harder to conduct because of this impact on pretest probability, on D-dimer, and on imaging test interpretation.
Well, thank you for this clarification. Of course, very important.
Okay, so you conducted an international prospective observational cohort study assessing the use of clinical decision rules in outpatients presenting to the emergency department with signs or symptoms suggestive of recurrent VTE. What are clinical decision rules and which ones did you use in this study?
Yeah, so clinical decision rules, they are scores or tools that you can use to stratify patients based on their risk of having the conditions that you're looking at, right? So, and usually it's made in cohorts where you have some patients who are suspected of the disease. In some of them, disease is confirmed, some is not. And then you try to link that to some patient characteristics. And it helps deciding, having a scoring system based on presence of symptoms, risk factors, findings, and it gives you a number of points. And the more points you have, the more likely you are to truly have the disease. And we can use that in combination with other tests to make a more efficient diagnostic algorithm. Which one did we use? Well, so for in the field of VTE, for DVT, there is only one that was really strongly validated and used. It's a Wells score for DVT, has been in use for more than 20 years. For PE, there is a bit more diversity. So there is a Wells score for PE as well. There is a revised Geneva score, which is maybe more in use in Europe. And these are the ones that we did use in the study, right, Vicky? Am I missing anything? No,
No, it's correct.
Okay, wonderful. So now let's dig into the details of the study. Could you tell us about the participants you recruited and specifically how many were on anticoagulation at the time of recruitment?
So we're able to include 723 patients who had a prior history of VTE and who were coming with signs or symptoms of recurrent clot. And specifically, 322 patients were on anticoagulation, so representing 45% of our population. The dose of the anticoagulation was variable, so some of the patients had therapeutic dose of anticoagulation, some had an intermediate dose, and some had a prophylactic dose.
Okay, so let's move on to the results. What did you find regarding those with suspicion for isolated DVT?
In patients who had a suspicion of isolated DVT, I'll also comment at the same time in patients who had a suspicion of isolated PE because they had similar results, like comparable results. So we did find that the proportion of patients was higher in higher risk categories. So most of the patients were categorized in the higher risk group. So likely risk group if we use the 2-level score, or moderate or high risk group if we use the 3-level scores. We also saw that the prevalence of VTE per risk group was quite comparable to studies that derived and validated these clinical decision rules. So, of course, there are some exceptions, but mostly it was quite comparable.
Right. And what about those who had suspicion of isolated PE?
So they had a similar result as those who had isolated DVT. So they were mostly categorized in higher risk groups, but the prevalence of P per risk group was comparable to studies that derived and validated these clinical decision rules that we used.
Right.
And then how about for those with suspicion of combined DVT and PE?
Yeah, unfortunately, our clinical decision rules that we evaluated appear to perform poorly. They did not seem to categorize adequately patient in each risk group. So for now, we do not really know which clinical decision rule would be the most optimal to use in this subgroup of patients. The number of patients in this subgroup was quite small.
and we struggled with that group, right? We even to analyze it, we weren't sure how to handle that because if you think about it, when a patient comes in with a suspected isolated DVT, that means that they don't have any PE symptoms, right? But when you look at the Wells score for PE or the revised Geneva score for PE, actually whether they have symptoms or signs of DVT is part of the assessment of patient with suspected PE. And it made us reflect a bit on that, right? So, and sometimes actually you have patients who come in with a suspected PE and you ask about the legs, and sometimes they do bring up some symptoms, yet if they are found not to have a PE, physicians might decide not to pursue any specific investigation for DVT. And in other patients, if there is a true suspicion of having both, then even if the CT of the chest is negative, for example, they will keep going with the ultrasound of the legs. But that distinction isn't actually very clear, right? So in the study, we were asking, okay, do you have is there a suspicion of DVT? Is there a suspicion of PE? Is there a suspicion of both? But you can see that there is some nuances around that. Maybe the isolated DVTs is easier to identify. The two others are a bit of a mixed group, I think.
Right. So in terms of predicting recurrent VTE, were anticoagulation status and D-dimer helpful?
It's a very interesting question. So if I take these two predictive factor by itself, if we looked at the prevalence of VT in patients who were on anticoagulation, we did see that it was lower. It was around 15% compared to 38% in patients who were not on anticoagulation. So with the prevalence of VTE of 15%, it is not low enough to exclude VTE based on the anticoagulation status by itself, but we do see that the diagnosis is less likely but not impossible. So of course, if we have a suspicion of recurrent VT in patients who are on anticoagulation, investigation should be pursued to exclude a recurrent clot.
Very important message for clinicians, right? Because sometimes it's easy to think, oh, okay, well, anyways, they're on treatment, so it can't be that. Well, indeed it can.
Right.
And on the other side, not being on anticoagulation could possibly be a predictive factor of recurrent clot in this population too.
Mm-hmm.
If we look at D-dimer in patients who have a suspicion of recurrent clot, we did see in our population, and we have to nuance it because it's small numbers. But in patients who had a suspicion of isolated DVT, using D-dimer in patients who had a suspicion of isolated DVT did not seem safe enough because the prevalence we have of DVT in patients who had a suspicion of isolated DVT with negative D-dimer was 7%, which is not low enough to exclude a recurrent clot in this population. As for patients who had a PE, who had a suspicion of PE with or without DVT, there was no recurrence among patients who had a negative D-dimer. But of course, the sample size was small in this subgroup. So it did seem safe, but the number of patients was quite low.
Okay. So one thing we often see in clinical practice is the D-dimer to, I guess, rule out VTE, and that's done in patients on anticoagulation as well, but we don't have a lot of data there. So from your study findings, should we be interpreting D-dimer differently in patients on anticoagulation compared to those off anticoagulation?
It's actually an excellent question. And we had that question from a lot of clinicians who are interested in specifically on this question. And I think it will be something we'll work on and we'll look at for a future paper in this cohort, because we would like to know, is there a cutoff that would be safe, a D-dimer cutoff that would be safe in patients who are on anticoagulation? So it will be something that we'll work on.
Right. Okay, well, you've done a lot of work here and you have some findings. Could you summarize the implications of these findings to us?
Well, I think a first one maybe is, again, that it's common, and that despite the fact that some patients might come very often presenting with symptoms, and despite the fact that there could be concerns about recurrence because they have had events before and so on, we did confirm the recurrence in a big proportion of cases, right? So certainly message number one to me is don't ignore symptoms in patients who have had clots before. Yes, they might be worried about it, but actually they're right to be worried.
Right. Anything to add, Dr. Ming?
I think that the other thing is it seemed adequate to use these clinical decision rules in patients who had an isolated DVT, a suspicion of isolated DVT or isolated PE, whereas in patient with a presentation of a suspicion of PE with DVT, we do not know. I think that's the second message we could take. The third one would be probably even if your patient is on anticoagulation and they have signs or symptoms of recurrent VTE, we cannot rule out VT only by the anticoagulation status by itself.
Mhm.
Okay, thanks. That's very helpful. So is there anything that we haven't discussed today that you'd like to add?
No, I think so. We stay tuned for next step, right? As you said before, I think looking into more details at D-dimer use in anticoagulated patient is something we want to do, and we had some other ancillary analysis coming up, right, about suspected ipsilateral DVT, and we want also to use that data to do some external validation of other prediction scoring systems that are out there. So more data to come out of the predictor study.
Excellent. Thank you so much.
Thank you all for the great discussion. And it's great having you, Vicky and Grégoire, on the podcast again. We've had you on a couple times with our ISTH special events. So it's great to have recurring participants. It was terrific to have you here today. So to read the full publication, the link is in the program notes. And thank you to our audience for joining us on Clot Conversations. We love hearing from you, so send your comments, questions, and ideas for future episodes to info@thrombosiscanada.ca. Want to stay up to date on the latest in thrombosis? Hit the follow button so you never miss an episode. And don't forget to visit thrombosiscanada.ca for a wealth of resources, including clinical tools, patient guides, and information on our annual conference coming up this fall. Your support matters, so consider donating to Thrombosis Canada to help us continue the fight against thrombosis. Appreciate it all. Thank you.
Thanks.
Excellent.
Guys.
Yeah, thanks, everyone.
Thank you. Thank you.
That's terrific. Appreciate it and appreciate your time.
Good.
All right.
Good. Thanks for having us.